team panelist and the moderator to come on to the dais. The topic was From Legislation to Practice, How Policies Affect Family Medicine. Moderator, Dr. Vijay sir, and the panelists, Dr. Vandana Bubna, Dr. Rashmi S. Kaimal, Dr. Raman Kumar, Dr. R. Ramesh, and Dr. Abdul Raskti. Please take the dais.
So I welcome everyone back onto the stage. The clock will not only tick, ma'am. May I request the clock to be reset to 12 minutes? Yeah. At 10 minutes, we will start winding up, and 2 minutes for the closing remarks. Welcome back, Raman sir. Thank you. So we had just finished our concluding remarks to the previous question by Ramesh sir. So the next question is to Raman sir. Sir, with legislations always threatening to affect our practice, we are talking here about how it affects our individual practice, a closer kind of a focus. Now, if I earn, say, 150 rupees in a consultation, which takes about 15 minutes, usually the employer takes about 50 rupees away. From the remaining 100 rupees, I pay about 10 to 20% tax. If I'm lucky, 20%, usually 10%. From the remaining 90 rupees, I still pay GST if I have an ice cream, costing about 90 rupees, say. So the cost of the ice cream might be 75 rupees and 50 rupees is GST. So actually, if my kid has to have an ice cream, first I have to earn 150 rupees. That's one point. Now, that's in Kerala. Maybe in other parts of India, even general practitioners are charging 1,000, 2,000 in one consultation. So that's a different story. So my question was, with all these legislations to be complied with, or if we don't, we are threatened with, how do we balance so much of expense and maintain a healthy income in this present scenario?
So, the challenge with medical professionals in general, we don't have financial education. I mean, starting from taxations, the income part, expense part, and how the government behaves to us in that sense, and how we respond to the government regulations. We have lesser information about the financial things and also legality of it as compared to other professions. For example, management graduates, even law graduates, they will know better than us because we are not dealing with those things in our education system. And our education system is entirely, it is out of the general education system. Like university, medical education system is totally centrally driven, like NMC Act. There is no role of university as such. Now there is exit examination, which is universal. There will be exit examination. So in general, we don't have education on management, law, corporate laws, and how do we manage our funds and income. That is a separate education that we need to learn. So one part is it is pinching hard on our pocket, on our lifestyles. But the other smarter ways to learn how to save money, how to earn money, how to expand our income base, and how to, there are other avenues of investment, earning money. All doctors are not earning money only from the patient consultation. They're also earning from share market. They're also earning from real estate investment. They're also opening restaurants. They're also running pharmacy business. They're running hospitals. They're running diagnostic centers. So just by professional income, it is not sufficient at the moment because there's too much of competition in the urban areas, especially all parts of India. Even super specialists, any qualification, any institution will not get any campus interview. There's no packages. No doctors is charging 5,000 rupees consultation fees in India. Whereas advocates are charging, IIT graduates are getting, millions of dollars and, things in income. So medical profession is different that way. It is like free service, free air, free water, and free doctor. Kind of mentality is there in the society. Still, we have to make our life better in it. So we learn more financially, the way to balance it, to be more financially educated. I always advise at the conferences, there is a book called Romancing the Balance Sheet by Anil Lamba. It is a very popular book. It is for financial education for lay persons. Romancing with balance sheets. So what is credit, debit, income, expense, loans, all these things, when we understand, we will be able to use better use of money. Legislation part will always be there. There are high-tech systems in Canada, UK, Germany, as compared to India. In India, we are complaining because we are not getting same value out of it, out of the taxation that we are paying. We are not getting good education free of cost. We are not getting good health system free of cost, where the Canadians are getting it, Germans are getting it. We are not getting it. So we are at the receiving end of the taxation system, even if it is slightly lower than those countries. But that will improve once the economic situation of the country improves and our all income, education on financial things improve. That is my take on this.
Thank you, sir. I hope the next generation is listening, of PGs especially. Perhaps the best way to do family practice is nowadays open your own practice. So, Rashmi, and before we move on to you, I just had a follow-up question for Ramesh sir also. And all the panelists in general. Now in Calicut city where I practice, about 4 nursing homes, very historical nursing homes have actually shut down after the Clinical Establishment Act came in. The reason being they're not able to sustain in view of the increasing expenses and the cost or the income being still very low. It was very effective primary care they were giving, but they could not sustain. So should we be scared look into the future as young doctors who are sitting here who will be planning to open their practice?
See, the problem is we should not be scared about the legislations. The legislations are definitely to come. We may not be able to stop it because all the policymakers, the politicians, the minister, everyone, they are all pro-people. They are not going to help our profession. They will only think about what people want and how they can satisfy the population in general. And health being a very sensitive issue, I think it's a major issue whenever a political discussion takes place also. So that legislations will definitely come. So what I would say to my professional colleagues is, let us not get too much carried away by these legislations, but we should be aware of what these legislations mean to us. And always, we also should have one feeling in our own way that quality sparkles. And whatever we do, whatever practice we do, whether it's a general practice or a specialty practice, the quality of the service really matters. And we should try to correct ourselves and do as per the rules, maintain ethical practice, maintain all your professional ethics. And I think you need not worry much about the legislation. But here there's a catch. There are certain acts which our medical professionals may not be aware of unless they get indicted into it, like POXO Act. How many of our professional colleagues understand what is it and what the POXO Act demands from a medical practitioner? Similarly, PCPNDT Act. And there are also a lot of clauses in the latest BNS where we need to be aware of. So not getting too carried away, but at the same time, we should try to be aware of all the acts which can govern us in our day-to-day practice and try to follow the rules and laws of the land, and which are actually harming to us. That is where the organizations like IMA and AFPI, everyone can step in and have a discussion with the government and try to modify the legislation so that even the professionals are also comfortable.
Thank you, sir. Thank you so much. We are having 4 more minutes on the clock. We'll just keep on again, Rashmi madam, because money matters more than academics right now. So the next question is, I'm just joking, okay? I don't mean it really. Ma'am, Vanda ma'am, some states, especially in your neighborhood, some states are trying to cap the consultant fees of doctors. They are passing legislations that MBBS doctors should be charging 100, PG 200, and specialty 300. Now, do you see the trend getting successful, or do you think it will not?
See, I can speak 2, 3. I just want to add 2, 3 points. One, doctors earn later in life. This is what my experience from the professional. Me and my sister, we are 1 year apart. They are living in a mahal and I'm living in a MIT flat till date. Worked together and started together only. Number two, we should really learn to manage our finances. During COVID time, suddenly we just worked. We never knew what was coming to our accounts or in anything else. And suddenly I had to write a big check to the income tax. I did not know. I didn't earn anything. I just paid the tax. So apart from the skills, we have to learn other areas only. Number three, that you can spread your skills. As a family physician, your arena is very wide to earn. You should keep ECGs, you can keep medicines, you can keep vaccines, you can do home visits, you can do geriatric care, you can do palliative care. There is no end to it. So wide arena of earning, and you can increase your earning. Number four, as far as the capping of fees is concerned, universally putting a similar fee structure to all the doctors, I do not agree to it. If it is as per the discussion with the doctor policy maker and the health policy makers, and that you can keep this much of fees as per the community you are catering to and the facilities you are providing to, and as per the your practice resources, whatever you provide, you can go to that extent. I think it will be okay to have a universal coverage, better access, and better giving care to the community. So it should be a balanced act. Otherwise, in the area of Jharkhand and Bihar side, I have lots of friends over there, and there's lots of hues and cries regarding the capping of fees over there.
Thank you, ma'am. Thanks for the input. The last question is to Rashmi, madam. Actually, I kept it purposefully to the last. Ma'am, from the legislative point of view, being an academician, what do you think you could teach your PGs, or in general, all PGs in family medicine in India should be trained in, more specifically in the current era?
So, the thing is, regarding legislations, as I told in the inaugural function, there are many legislations acts which mandate family medicine, which are there but not in practice. One is the NMC Act in 2019, which says that there should be family medicine in the undergraduate curriculum, which has not yet been in place. It is an act. And another is another act which has urged to increase the postgraduate seats in family medicine. So, which is also still remaining as an act. As we all know, the only government medical college other than the AIMS is still only one, government medical college. So these acts, so before I wind up, I would like to contradict you on the point you said earlier that money matters more than academics. At this stage, to young family physicians, I would say that academics matters more than money.
Yeah.
Not just academics. You have to be updated in your knowledge and prove that the legislations will happen. It depends on the politicians and the vote and their vote bank and all those things. But what we can do is we can make a difference in the communities that we treat and show that you have to create this legislations because it benefits the community, or you have to make this into action because. So that is what young family physicians should strive for, to work in a way that the legislature, the policymakers make note that this should be done.
Yeah.
I think that
That
summarizes
it
my
well.
take
Thank you,
on
ma'am.
this.
Thank you, ma'am. And of course, I meant that line as a joke, okay? Okay. Now to conclude, I'll just say a small thing. I think Ramesh sir, Raman sir, all of you should be aware of this. I did a pilot study in a very small health center where I was working till about 2 years ago. For 6 months, I made a database of how many people were planning to go to tertiary center, especially private hospitals. And they used to have this perception that this doctor may be able to manage it. So those kind of patients, I used to ask them, where are you going to get admitted? And take a rough estimate of how much they would spend if they went there. When I used to give them an option, like uncomplicated appendicitis, uncomplicated pyelonephritis otherwise, like pre-septic stages, diabetic ketoacidosis, severe hypernatremias, some cases needing observation actually in a secondary level hospital. I used to give them an option whether you want to get treated here or you want to get referred to. Most of them actually opted to get treated there only, because by that time the word of mouth had spread that this will save us money. So used to get them to sign the consent and then only treat them. If any complication happens, you have to immediately go to the tertiary hospital. Out of 10, every 9 patients actually survived from there or got better from there. Maybe one odd case didn't. Like they had to be referred even then. At the end of 6 months, when I calculated, just I will take a very underestimated value. 3 patients if we save per week like this, okay, and appendicitis or a pyelonephritis which you think is stable, which you can manage with ceftax and supportive measures, it would cost them at least 30 to 40,000 in a private hospital, let's say corporate. It would cost them about less than 4 or 5,000 rupees here. You are saving 25-30,000 rupees per patient over there. 3 patients a week is about almost like 75,000 to 1 lakh rupees. 52 weeks in a year, that's you are saving 50 lakh rupees. I was able to save in that one clinic, working half a day. That is the niche of family medicine, is what I would say. And this spread by a word of mouth. There was no advertising at all. It is just the community which spread the word. And this was a pilot study, so it was not officially documented, though I had kept a register which I had handed over to one of my colleagues. And why I'm telling this in this forum with such lack of time is that this should be a multi-centric study. Imagine one doctor working half a day able to save 50 lakhs from the community. 10 doctors we have in a 10-kilometer radius right there. How much amount of money we are saving. Imagine that extrapolated to the state and the country. That is where we are adding to the public healthcare savings. I think this is the message which should be reaching right to the top level. We can generate data once again. If I could do it, each one of us can do it. So be inspired, be bold, be brave, follow the legislations, document it, take consent. If they are willing to get admitted under you, do it as a daycare procedure and send them back. And document the financial savings also, not just the savings of morbidity and mortality. Financial savings also should be documented. This will take us forward in the next, not 10 years, in the next 2 years. We are right there. We just have to document it properly. Thank you very much. Thank you to all the panelists for having contributed wonderfully to our conference. Bottom of my heart, heartfelt thanks from all of us. Thank you, sir.
Attention please. I request the owner of the vehicle KL 841734 to contact the organizing team immediately. Again, KL 841734.
Now I invite Dr. Parmendra Prasad Gupta, President-elect for WONCA South Asia region, to present the memento to the panelist and moderator. Dr. Aman Kumar. Dr. Vandana Bubna. Dr. Rashmi S. Kaimal. Dr. R. Ramesh. Dr. Abdul Rasik T. Thank you, sir. Dr. Bijay Raj, the moderator of the session. Thank you, sir.
In a system where patients are seen in splits of different organ systems, we as family physicians play a critical role in providing holistic, continuous, and comprehensive care to individuals. We should urge the policymakers that legislation should be made such that peripheral health centers are manned by family physicians to change the face of our primary care. Also, more PGCs should be brought about and existing institutions should be strengthened with OPs and wards under family physicians itself. It was an enlightening session and a much needed topic. Thanks to the moderator and the panelists for your valuable time and insights. Thank you.
Moving on, next I invite Dr. P.K. Shashidharan sir for his lecture on the shaping the future of family medicine. Professor P.K. Shashidharan sir is the former HOD, Medicine and Hematology, Government Medical College, Kozhikode. He is the Emeritus Professor, Department of Family Medicine, the Academic Head of Astor MIMS Calicut, past President, Indian Society of Hematology, a former Dean, Faculty of Medicine, University of Calicut. He authors many books such as Doctor's Pocket's Companion, Guide to Clinical Practice in the Post-COVID World, Healthy India, Heal Thy World, chapters in textbooks of medicine, and so on. Welcome, Dr. P.K. Shashidharan sir.
It seems the chairperson hasn't arrived.
I invite Dr. Kailas and Dr. Seren Kuriakose to chair the session.
Good morning, all. At the outset, let me thank the organizers of AFPI 25 for giving me this opportunity to stand before you to give some thoughts on how we can shape the future of family practice in India. What I am talking here is based on what I presented before the Niti Aayog once during COVID times on how to promote family medicine in India, based on which very crucial decisions were taken after that. And the same points were used in filing a public interest litigation in the High Court of Kerala. And the Honorable Court also has taken favorable decision in favor of promoting family medicine. I have no conflict of interest, nothing to disclose. I promote the concept of family medicine or family practice just for the benefit of the society. There are no personal gains. If at all, I stand to lose only because my own colleagues in internal medicine think that I am working against internal medicine. This is the attitude of doctors who do not know what is the importance of family practice. Because social health is my only objective in promoting this concept. We must know that bad trends are multiplying in the profession and the society. There are no modern medicine doctors now to connect well with people. But the alternative system people are connecting well with people. There are no trained or dedicated or competent doctors to run the PHCs. We just have changed the name to FHCs. Just now I got an opportunity, that is when with the speaker, I told him that the doctors sitting in the PHC should be trained in family medicine. He could understand that concept and we plan to discuss it later. PHC cannot become true FHC unless they are manned by trained family doctors. That's the single most important point they should know. Disease burden in hospitals is increasing because of their absence. Diagnosis gets delayed, complicated and incomplete also. That's another point. Increasing number of tertiary care hospitals, it is an artificially increased need. The tertiary care hospitals are increasing. It's a purely an artificially increased need. There is no need to increase the number of tertiary care hospitals. Most of these things are known to you, but I'm just summarizing all of them because the younger generation has to take it up. Just because there is an artificially increased number of tertiary care hospitals, there is an increased need for specialists also. And increasing out-of-pocket expenditure for the people. We design medical education to bring out only specialists. It's a never-ending vicious cycle. We need to break it somewhere to save India. There is nobody to get the people scientifically and to connect well with people. Hospital attacks are happening, doctors are attacked only because there are no doctors to connect with the people. If only referred cases are reaching the hospital, nobody would attract the doctors or hospitals. People are guided by religious leaders. Actually, family doctors would have guided them. There are nobody to guide them. It is religious leaders who are guiding them. Or governments, which we have in plenty. Astrologers, consumerist forces. These are the people who guide the people now. Increasing sexual violence and moral policing also is the outcome of not having different philosopher kind of doctors. Medical education hospitals have just become industries only now. Unscientific traditional practices are growing everywhere in India. Why Ayush is multiplying? Why the government is promoting Ayush? Because there are no family doctors. That's another bad effect which we should know. I'm not against Ayush, but Ayush is not the solution for scientific primary care. SPM has disappeared. Once we had social and preventive medicine, they just changed to community medicine. God knows for what. It is against their principle of work. And my connection with family medicine, I started studying pitfalls in our health system since 1986 onwards. And that's why I left PGI without a DM. In 1987, when I went to Munnar tea estate, I realized the importance of family doctors and the good work they do there. I found that in the Munnar tea estate, which was under the control of Britishers, just changed over to Anandavan tea, and they had 35 PHCs in the estates itself, and all these doctors were in charge of the health of the people. In one of the employees developed typhoid, cholera, or dysentery, one increment of the doctor would have been cut. That gave me an important lesson in 1987. That same year, I happened to visit England and witness the GP system in England. Immediately after coming back, I gave a proposal to start family medicine in India and in Calicut Medical College. That is, but it materialized only in 2012. This is how I started working on it. And I started realizing the relevance in India due to the problems that we faced, and I started exploring health systems in different countries, directly traveling there. Last one I traveled was to Japan. Wherever I went, I interact with the doctors and people to know how primary care is working in their country and how we can improve it. Just before going to the rest of it, I will just briefly say, why are family doctors needed in large numbers in India? Do we have any of these? Do our people get proper nutrition? None of us are eating a proper diet because nobody knows. And malnutrition is our biggest problem. Do we have safe drinking water? Tap water is not safe for drinking. And unchecked consumerism is promoted by all the market forces. And poor hygiene, poor waste management. These are the reason for all increasing number of patients. Patient load is increasing just because these public health issues are neglected. Are there any doctors working for public health? Who are the doctors who would be interested in public health? Only the family doctors. Ayush does not know anything about public health. They focus on individual health, if at all, that too in unscientific manner. The modern medicine doctors with interest in public health and scientific individual health are the family doctors. We have eliminated them. That is why all the bad runs in India are happening. Malnutrition and poor lifestyle and unchecked consumerism is a deadly combination, and all these bad things are happening, and you have a package of diseases. Infections are flourishing on one side, and on the other side, the non-communicable diseases. And we are number one in disease burden in the world. We are not looking at the statistics. If you name any disease where we are number two, any disease, we are not behind anyone in any disease. Infections, strokes, cancers, hemophilia even genetic disorders. Because fresh genetic mutations occur in the background of poor public health, malnutrition and wrong lifestyle. Mental illness, blindness, road traffic accidents, malnutrition, under-5 malnutrition, poor public health. Everywhere we are number one. Slums in cities. So, because there is nobody to get the people on scientific public health. Specialists in corporate hospital, we are number one actually. We have the largest number of specialists now in the world. But there is no organized primary care or family practice to guide the people. Even people fall into debt traps after treatment. With limited resources, only we spend only 2% of our GDP on so-called healthcare, which is only tertiary care. When people said healthcare, it is only tertiary care. There is no healthcare in India. We manufactured disease because we ignored all the basics. And we ignored public health and primary care. And we were preparing tertiary care facilities only for treatment. This is a bad trend that has happened in India. And the result is overcrowding in all the hospitals, tertiary care hospitals. This is a medical college where I was working. Patients were admitted in the verandas and doctors were taking rounds there and investigations are done on the floor. All these are the result of, this is a medical college in Calcutta. This is a trolley I found in one of the hospitals when I went as an examiner. So the poor things, trends, bad trends are happening everywhere in India. What is the kind of disease care needed with the highest disease burden in the world? There should be doctors who are capable of making prompt diagnosis, give prompt treatment in the community setting and proper treatment, less investigations, provide cost effectiveness, providing person-centered care, holistic approach, interest in health and wellness of the people. This is all possible only with trained family doctors. That's one thing we have to know. This is another thing people and doctors are not aware of. There are some very crucial facts about clinical practice and making diagnosis. Diagnosis is always made by clinical skill, not by laboratory. I am now seeing only referred cases sitting in a tertiary corporate hospital after retirement. I accept only patients who are referred by the doctor sitting outside. Even in them, 90% of my diagnosis comes from good history. Very little comes from physical examination, and very little comes from investigations. But where is the focus now? Even laboratories are doing health checkup in the name of healthcare. We need doctors who diagnose and manage all common problems. 90% of problems can be managed in the community level. GPs and family doctors are the most important for any sensible society. Doctors who work in larger hospitals are less needed in lesser numbers, very lower numbers. Doctors who work for prevention of disease are more important. Who are they? The SPM, Social and Preventive Medicine. It has disappeared in India. They just changed to community medicine. I don't know for what reason. You must know that the meaning of doctor means teacher. Teaching what? Teaching about good lifestyle habits, diet and all. Teaching about public health. Unless we do that, we are not even worth the name of calling ourselves as doctors. The doctor is a teacher. Without being a teacher, you are not even a doctor. We need doctors with 360-degree vision on individual health and public health, not just individual health. And the GPs and family doctors can only get that kind of insight. And the COVID mismanagement happened all over the world due to lack of influence on policymakers by family doctors. And again, this is one confusion among the youngsters. Youngsters do not know what is the difference between all these. These are all same. Family doctor, general practitioner, primary care doctor, doctor of first contact. All these are one or the same only, and it should be good trained family doctors. How many of you know the objectives of MBBS? In fact, the NLC director didn't know this. This is the reality because I went to Delhi headquarters of NMC, those days MCI, to formulate the curriculum and syllabus for MD family medicine. And I started off with this slide projected on the screen, and the MCI chairperson asked me, where did you get it from? I said, I got it from the MCI website. This is a situation. I'm not joking, this is a cruel joke which is happening in India because nobody is aware of the objectives of MBBS. Then there are some people think that MBBS is enough to make family doctors. The MBBS is to sensitize you into family practice. But you will never become a family doctor after MBBS. That is another hard thing that you have to know. You need to work, by trial and error you can become. That was happening 50 years ago, some 70 years ago. Now it is not possible. Present day MBBS doctors, even if they try, they can never become true family doctors because of the kind of training that is going on. Because it is all specialty oriented. Nobody knows the objectives of MBBS. So these objectives are clearly meant to bring out family doctors, but it is not enough to make them competent and confident, independently practicing family doctors. The 3-year training is for capacity building and to make them confident and competent. So the definition of ideal journalist, family doctor, all of you know. I don't have to repeat. These are the things which makes you a very good family doctor. Familiarity with the individuals, families, and society. That is how you are able to connect well with people and people-friendly doctors. This group of doctors are the most important in any society. They are not just physicians. They are friend, philosopher, and guides to individuals and families, both in healthcare and in disease care. It's a challenging job, but most satisfying. That's what I realized throughout my profession. I was actually regretting that I did not become a family doctor. Because by the time I realized I'm already into the teaching profession, I would have become a family doctor if I had known this earlier. That's my thought. And these are the only doctors who practice medicine both as an art and science. And remember that, one more thing. I go to a medical college, Calicut, to address the first-year MBBS students. And they were all afraid of listening to what is happening in the media. AI will one day replace doctors. Do you ever think that it will happen? It will never happen. And this will never happen in family practice. If at all it can replace radiologists, ophthalmologists, kind of people, the fundus pictures and all can be looked at by the AI. But doctors in primary care, family practice, can never be replaced by AI. And they should be the highest paid, most respected. These are policy changes. The points, some of these panelists were discussing were guidelines on implementing policies. That they are not policies themselves. Policies should be aimed at increasing primary care improving primary care in the country. These are the objectives of family medicine that we should always think of. Make treatment cost effective, irrespective of age and gender, including palliative care. Why palliative care has grown in India like anything? It has become another specialty because there are no organized primary care. If you have organized primary care and large number of primary care doctors, it means don't think primary care is inferior. I use the word primary care because they are the doctors of first contact. If you have good family doctors, palliative care is not necessary even, because palliative care will become part of the primary care. Actually, these should be integrated. Palliative care has to be integrated with primary care. That's another point we have to discuss in policy matters. And these are the only doctors who promote wellness. They are the gatekeepers, whistleblowers for public health. When a cholera outbreak or a viral hepatitis outbreak occurs, these are the doctors who can tell what is needed to prevent it. Who will otherwise address? When an all-party meeting, when hepatitis A outbreak came, I went to attend a meeting and they were all crying for hepatitis A, IgM immunoglobulin, and IgM kit for diagnosis, rather than talking about safe drinking water and personal hygiene and community health. They're not bothered about basic issues. People go away from the basic issues just because we do not have family doctors. Wellness, happiness, we discuss often, but what is wellness and happiness? It's an issue of public health, social security, and human development. Sound individuals are possible only in a sound society. Like when we say sound mind in a sound body, healthy individuals are the reflection of a healthy society. The backbone of building a healthy society is well-trained primary care doctors. It's not possible. Happiness or health as such, or public health, is not possible with cure-all capsules, the traditional wellness centers and hospitals. Family doctors are the only doctors with interest in social health and public health and scientific public health. Why India is not very happy? Hope you know the position of India in happiness index. Even in 2024, it is 126 out of 140 countries. Then we criticize the criteria made for making happiness index. That's not what we are supposed to do. Why we are behind happiness index? Absence of family doctors, I would see as number one issue. Because they are the people who can sensitize people on public health needs and good lifestyle habits. And that will change the policies. lack of good primary education. Because the primary education has to instill humanness, wrong agricultural practices, massive single crop controlled cultivation is going on, poor utilization of resources. These are the reasons for poor happiness index in India. Due to absence of experienced family practitioners, there are no organized plans to teach or promote good lifestyle habits. There is no one to sensitize policymakers on genuine public health needs. We just talk about lifestyle diseases and bring medicines and distribute medicines. That's not what is needed. People should be taught about good lifestyle. What is good lifestyle? I will not elaborate on any of these. All these good lifestyle habits have to be taught and people should be motivated to practice it. Who will do that? You expect the Ayush people to do it? That's what is happening in India. Ayush cannot do it scientifically. They can come with some quick fix remedies, but they will never be able to do it. It is a family doctor who can take up that challenge. And we can do health education through the PHC using the health team. You are large number of health people there, you can utilize them. And we can attach to some school health programs where we can educate students on good lifestyle habits. These are the paradox. The people in administration, doctors are unaware of the importance. Even those who take up family practice are unaware of the importance of family practice. And there is no accepted family practice guidelines in our India. People ask for cath labs, dialysis centers, and transplant centers. Even the Kerala government, in spite of all the good things they are doing, they think that transplant center is more important than setting up proper PHCs. This kind of wrong attitude is only because we do not have enough family doctors. Emergency medicine, they think it is very important. More important is family medicine, but people fail to look at that. Palliative care, they are aware of. People are aware of emergency medicine and palliative care. They are not aware of family practice. So we need to create awareness. That is another point. Family medicine, no one knows, but is the most important. And then why PG training in family medicine is needed? I hinted at that. MBBS plus dedicated work experience for 4 to 5 years is enough, was enough. Now it is not enough because the present MBBS does not even sensitize. Like Dr. Esmi Kaimal was telling that MBBS students have to be sensitized on family practice during this MBBS training. That is possible only when you have a family medicine department in each medical college. MD and DNB are needed only for capacity building, not MBBS doctors are not, MBBS cannot be enough to make them competent and confident, and also to make great faculties for training in family medicine. The students also will be satisfied if you have a degree, because everyone wants a PE degree these days after MBBS. There is a need to deliberate on family medicine only due to lack of awareness. Why should we discuss this? It should be part of our culture. Actually, that is not happening. Had people know its relevance, everyone would have asked for it. Everyone, including the speaker, would have asked for it. Why he is not even aware of it? Because there are no family doctors. The wrong policies, wrong prioritization of resources, or due to the wrong advices reaching the policymakers. Who are the chairs of doctors' bodies, IMA including, most often specialists. Why? The majority are specialists here. So the policies are different. That is what happens. In South Africa, I found that during COVID times, it is the chairperson was a family doctor. So they gave the right advice to the government. Even in England, the policies changed because the family doctors were heading the British Medical Association. Here what happens, maybe a neurosurgeon may be heading the team, and or the cardiologist or neurologist may be heading the IMA. They cannot make policy changes, right kind of policy changes for the government. So wrong advices finally reach the decision makers and planners. This is happening again because we do not have family doctors. So we need to work hard to tell all these policy matters to the decision makers. Till 1970, all MBBS doctors were working only as family doctors. And those days, students had the objective to work as family doctor. When we were students, I had only one objective, to become a good GP. But at the end of MBBS, I realized that I'm not competent. But I wanted to be a teacher. My primary ambition was to become a teacher. That's why I went for a teaching job. Otherwise, if there was a possibility, I would have gone for family practice. And in 4 to 5 years, they all matured to become good family doctors. But even in 1980s, I am very confident to say that MBBS alone was not enough to make you a good family doctor, even in those days. Now the present situation is different. Since we have no policy, all these doctors who naturally became family doctors vanished over time, and they became extinct also. And because family practice is never promoted by plan in India. There is lack of awareness among doctors, MBBS students and public. Now people ask, what is it? Why do we need them? I had to even, the 5 minutes I got, I had to explain to the speaker. Or we were explaining to them. Once in a university meeting, VC of a university asked me, what is family medicine? What is general medicine? What is community medicine? It's a very, very sad situation. The resistance to promote family medicine is simply due to lack of awareness. So we need to break that problem. And one specialist in Bangalore who controls the central government, I'll tell the name of him, Dr. Devi Shetty. He cries for specialists in India. Every doctor has to be made a specialist. I don't know what he means. And he says all doctors should be trained in general, cardiology, neurology kind of things. And that has changed the attitude in India. Now there are more than 1 lakh MBBS seats. And they are increasing the PG seats. It has gone up to 75,000 now. Even now, suppose you make even 1,07,000 PG seats in family medicine and means specialties, will it change the scenario in India? So, because these kind of people are misleading the government. So we need to create awareness against them also. One patient now needs 3 to 4 doctors at a time, even for minor ailments. Disease care is institutionalized with the freedom for doctor shopping. Doctor shopping is a business that happens nowhere in the world. India is the only country which promotes doctor shopping. We need to work against it. There is an artificially increased need for specialist doctors only because of this dangerous trend of doctor shopping. Even if all the MBBS seats are matching with the specialty seats, we will never be able to achieve proper health care unless we make majority of them as family doctors. These are some of the disturbing facts. All the MBBS graduates are now wasting time in entrance coaching centers. Do we need an entrance coaching? If you have opted for, like in Canada, 60 to 80% doctors willingly become family doctors. There is no entrance coaching, and only 20-30% go for specialization. This is happening all over the world. India alone promotes all these specialists. It is ridiculous for people to consult multiple doctors without a guidance. Even if they can afford to consult multiple specialists, their problems will never be solved. So what are the way forward and solutions? I just introduced you the problems in a nutshell which you all are aware of, but what are the way forward? What is the way forward solutions? This should be our dream. Unless we dream, we cannot make it happen. There is a point saying that it will not happen. It will happen if you have a dream and you work for it. People should consult only the designated family doctors. We should aim at that. We should have a family doctor. If you go to England or any other country, if you ask them who is your doctor, they will say, so and so is my doctor. They will consult only that doctor. They will not go to anybody else. Unless that person refers, he will not consult a specialist. He has no right to consult a specialist. This is what is happening everywhere else. Why should India alone have a wrong thing? Only when they refer, patients go to specialists or tertiary care hospitals. And specialists should be working only in hospitals, not in the peripheries. And this is what is happening in family doctors in other countries. All countries have family doctors except India. All the countries have family doctors. India alone did not promote family doctors. Now only you have started getting some family doctors because of training, but they are not even deployed properly. Countries from which we should learn are not USA, the Scandinavian countries, Canada, Australia, Cuba even. 250 families have got family doctor in Cuba. UK. UK is the base model for the family practice, but UK is now deteriorating. Even USA, the worst model in the world. I say it is worst because it's all private and insurance based, and 5 crores people have no affordability. They are not looked after in USA. If you have money, you will be looked after. That is happening in India now. So that is a worst model because there is no universal health coverage. And only people with money get proper health care in USA. That model is copied in India. That is the biggest reason for our failure. USA model is copied in India. But even in that USA model, 40% doctors are family doctors. They have family doctors in large numbers. And sensible people have an option to consult a family doctor. Here, even sensible people do not have an option because there are no family doctors. 40% doctors in USA are, again, general medicine doctors. Only 20% are specialists. India alone has this ridiculous system of promoting specialists alone, not even an internal medicine. This is the scenario in other countries. 60 to 80% doctors work as family doctors. The disease burden is low. That is another point you have to know. Because of proper social security and human development, and their disease burden is very, very low. I will just give an example. If you take the number of typhoid in USA and India, USA has good public health. There are just 450 patients with the typhoid in 1 year in USA. India has millions of typhoid in 1 year. You know who are the 450% with typhoid in USA? People from India, Pakistan, Mexico, and Bangladesh visiting there, carrying typhoid there. So that is the kind of public health they have. Do we think of that? How do we not, why are we not promoting that? This is only because we do not have enough family doctors. They should get more respect and salary too. The highest paid job in medical profession should be family doctors. This is what we should dream of. How do they function? It is not, there is no point discussing setting up private clinics and discussing about those details. They should ideally be part of a government system. Each person should have a family doctor. Every individual should have a family doctor. There should be a referral system, and universal insurance cover is a must. And running private clinics for the government is practiced in some countries like Denmark. I found that the family doctors are allowed to run private clinics, but the government is paying for the clinical doctor, family doctor. Even that can be done here. So anyway, it is working for the government. They are all working for the government, and the family care should be directly under the government, rather than discussing about how we can set up private clinics. But India, at least, people should be running private clinics when they are not absorbed into the health service. 3-tier referral system is there in everywhere. In Denmark, I found that it is not families which are attached. I forgot the number, it is 1,500 or 2,500 members, persons are attached to a family doctor. In Cuba, 250 families are registered with one family doctor. And they even do house visits, supervise health status, and sort out family issues, including psychological, social issues. And they lead a health team, and they are responsible for the health and disease care irrespective of age and gender, including obstetric, geriatric, psychiatric, and palliative care. Health of the family as a unit is looked after by them, continuous, comprehensive, all individuals. Direct assistant specialist is banned there. In Canada, it is UG degree plus 3-year PG training, as we have planned now. Family doctor stream is separate. Specialty stream is separate. At the end of MBBS, in Canada, majority doctors prefer to become family doctors. That's the kind of popularity they have for family practice. And they have equal status for in work and in academics and research. Health system is made for the people in Canada, Scandinavian countries, and even Australia. But India alone, health system is for the doctors who aim at profit making out of this profession. India and USA only make medical profession for the doctors. In other countries, medical profession is for the people. And then there are nurse practitioners in most of these countries. They run walk-in clinics. Even to attend a GP, they have to make appointment. And to bypass that time delay, they have nurse practitioners who work side by side with the family practitioners. So there is no point stopping nurse practitioners. We should have them, but they are not substitute for family doctors. They have to work along with the family doctors to actually complement the work of the family doctors. India should engage them, and they can be put in charge of sub-centers for the time being. And in fact, I was one of the members of a policy meeting in Kerala, and we suggested that they should be put in charge of sub-centers, but I don't know whether it is implemented. This is a disease care scenario in USA. Everything is under private. There is no universal insurance cover, but still the number you can see that majority are family doctors or internal medicine. And the new brand of internal medicine, now they have named internal medicine as hospitalist, because that is something which we all are dreaming of. Cardiologists, neurologists, so they are very fond of IST. So the hospitalist is the name for internal medicine doctors. Even this disorganized system has large number of family doctors in USA. This is from New England Journal of Medicine 2016 issue. I recently, 2 months ago, I visited Japan and found that there they also promote primary care, but their primary care doctors are the specialists who are engaged into primary care hospitals. So what happened is cardiologists, neurologists, nephrologists, orthopedics, ENT, ophthalmology, all may be sitting in PHCs in the remote periphery. What they did was they started practicing their specialty more than family practice. And they started investigating patients unnecessarily. Now the largest number of CT scans and MRI scans in the world are now in Japan. Only because of this wrong trend, the government has realized mistake. Now they have started family medicine training, and it has become a popular specialty in Japan. That is only one dark spot on Japan which I could detect. Now they are changing it. India still have not started thinking of changing this policy. The solutions are create awareness on all the health needs, empower people to have regular access to all the health needs. That will reduce the disease burden. A health system or disease care system cannot sustain unless the disease burden is low. This is one basic principle all doctors who work for policy changes are working for. Disease burden has to be low to make a disease care system sustainable. You will be spending all the money on transplant and treatment, and you will have no money left for providing safe drinking water and other things. So the burden of disease has to be low by making perfect public health, the social determinants of health. These are the social determinants of health: good agricultural practices to provide balanced diet, good primary education to instill humanness, large number of family doctors, safe drinking water. The tap water should be safe for drinking. Good waste management, everyone should have shelter, good sanitation, sewerage, and good lifestyle habits should be taught to everyone. And all these need a corruption-free society. That starts with good primary education. So primary care doctors should be aware of these basic issues which could influence policy changes, and that will change the policy of the governments. So this is a health pyramid that we should aim at. Social determinants of health or the basic health needs should be available to every individual in the society. That will reduce the disease burden. Then the most important doctors should be family doctors. And the decreasing number only, importance only given to the specialities. We need to, there is a special need for family medicine in India because nobody is aware of it. So we all have to take up advocacy work, which I have been doing from maybe for the last 20 years. I've been doing advocacy for family medicine, but still now the things have started changing. Maybe it has helped. It's a very important, crucial social work. Everyone has to take up that social work. It is something which our people are not aware of. We need to have strategies and policy changes, and we need to kickstart family medicine boldly with a family determination, rather than asking other people for their opinion, do we need it or not? It has to be started. And regarding you youngsters who take up family practice, you have to decide on one thing. Don't take up jobs in hospitals. That will work against the interest of family practice. You have to start private clinics of your own in periphery or go to PHC or CHC at the most, not above that. Never prefer to take up jobs in larger hospitals. If you take up jobs in larger hospitals, you will be defeating the program of family practice. Some hospitals are engaging them as RMOs, ICU doctors and all. This is going to kill the profession because you should say that I will not take up a job in a hospital. You have to sit in the periphery. Even in a hospital, if you go, it has to be doing family practice training, family medicine training. Then only it should be attached to a hospital. That is one thing you have to know. Otherwise, establish a private clinic. And you should always aspire for joining government service to get an appointment in PHC or CHC at the most. Never ask for reservation in super specialist courses. If you say, I have an MD family medicine, I want reservation in DM cardiology, then what is the point in doing family medicine? Never do that. It will again kill the profession. If you think of it, you joined with this practice without knowing what family medicine is. The market and try to market the concept of family practice by your job profile and by word of mouth. Talk to everyone, whoever you come across, to market family practice in India. How to scale up training programs. All medical colleges to have MD, DNB family medicine. All district hospitals and large general hospitals in private sector including can have DNB program or diploma at least in family medicine till we have a large number of PG seats. How to increase the job opportunities? Only trained family doctors be posted in PHC in future at least. It should be mandatory. Without training in family practice, you will not be appointed in a PHC or PHC at least. But if you are posted, you have to be trained compulsorily in family medicine. It should be mandatory. Advocacy to create 2 posts of assistant professor in each medical college. That's another important step that we are focused on in policy changes. Every medical college should have 2 assistant professor posts in family medicine to get recognition. They will slowly start the department and then the students will be exposed to family practice. This is important. Family practice has to be taught or they should be aware of. The MBBS students should know what is family practice. There should be somebody to teach them on the principles, and that is possible only if you post 2 qualified persons as assistant professors in family medicine, and slowly the department also will come up for training. I have been arguing with other people in the policy committee that family doctors will be a cure for our health system, and they laughed at me. In fact, the chairperson asked me exactly the sentence I can tell. Dr. Shashi's statement, Dr. Shashi പറയുന്നത് കേട്ടാൽ തോന്നും family practice ഒരു കാലൽ നെല്ലായി ആണെന്ന് തോന്നും. കാലൽ നെല്ലായി is a cure-all medicine. And he was laughing at me. And I said, it is a kalan nellai, it is a cure-all. I can explain to you, but they were not ready to listen to me. This happened 10 years ago when I was a member of the committee for policy making in Kerala. They laughed at me when I told this. And that is the reason why it is not taking off. And again, they are doing that lack of awareness, due to lack of awareness. I will not blame them. So policies will become public health oriented rather than treatment oriented only if you have good family doctors in large numbers. They will reduce the disease burden, reduce overcrowding in bigger hospitals, reduce the need for bigger hospitals, and will make diagnosis earlier and easier, and will stop attack on hospitals and doctors. This is a very important issue that we need to market family medicine among the people. And there is no conflict of interest or overlap between general medicine and community medicine. This is another point you all have to know. General medicine is to work in the hospital setting, not to work in the community setting. They are called hospitalists ideally. That is right. It is a generalist working in a hospital setting, but their patients keep on changing. The patients are not the same. But for a family doctor, the same set of patients coming repeatedly to the same doctor from home to tomb. And the community medicine is for, actually it is a misnomer, it is social and preventive medicine, it is for policy making. Policy has to be designed and there should be working for government. In Denmark, I found that the social and preventive medicine professor and HOD is the direct advisor to the government on policies. He writes policies for the government on healthcare. That's what should happen with the social and preventive medicine. They are not to compete with the family doctors. Now the social and preventive medicine thinks that they are the ideal people to train family doctors. That is another confusion in India now. So they should know their job and they should be put in higher positions. These are the long-term objectives that we should aim at. MBBS seats should be equal to PG seats, but majority has to become family doctors. There should not be entrance coaching at all. Suppose you have 107,000, more than 1 lakh MBBS seats. There should be equal number of PG seats, but at least 50% of them should be family doctors, at least 50%. And all this can be achieved slowly if we start now. Long-term objective is 60 to 80% of all doctors should be working as family doctors. That should be our long-term objective. And these were the basis for the public interest litigation which I had filed, spending my money on from my own pocket. There was nobody to support those days. It was all this for the larger objectives. The Honorable High Court was convinced of the arguments. Being a policy matter, they directed the government to intervene. That's all they could do. But they mentioned all the points which we mentioned in the litigation. This is what our final conclusion was. Following the interpretation, the court issued mandamus to concerned respondents, which included central government and Kerala government, including to create mandatory family medicine departments, all medical colleges to the union government, NMC, State of Kerala, and KUHS. Henceforth, posts in FHCs must be filled only with the doctors who receive specialized training in family medicine. But I don't know why the AFPI is not using this court verdict, which came 3 years ago. Nobody is aware of it. I have been sending it to everyone, but nobody is utilizing it. They issue a mandamus to State of Kerala and Kerala University of Health Science directing that existing doctors appointed in family health centers in Kerala must be given adequate and in-service training leading to a diploma or degree in family medicine. Court actually quoted all the points we mentioned in the judgment. So that judgment can be used for policy changes. So that means judges are convinced of the need. That's why they quoted all the points. Whatever we wrote, they used in the judgment also. Otherwise, they just give a one-line judgment saying that this is a policy matter you take to the government. Instead of that, they wrote all the points one by one and then wrote the judgment saying that it's a policy matter, we are referring it to the government. So we can use of that, make use of this particular PAL points. I will not read all of them. I can share with you if you want the PAL, which it is with me. They mentioned all the points that I have been telling right from beginning to until now. I will not read out. All these are mentioned in the PAL, and the court wrote one by one. All the points they rewrote and gave the judgment based on that. And if you want to read more about these things, I have written all these in the books that I have published. And the recently published book, Heal Thy World, even has given a chapter on policies needed for India, health policy needed for India, with bullet points I have given that. And this book we have revised to make it useful for the family doctors in India. Thank you.
Thank you, Dr. P.K. Shashidharan, sir, for that enlightening talk. Now I invite Dr. R. Ramesh, former DHS, IMA National Vice President-elect, to hand over the memento to Dr. P.K. Shashidharan, sir. Dr. Serin Kuriakose is required at another venue, so I would request Dr. Vijayaraj, sir, to chair the next session alongside Dr. Kailas. I request Dr. Kailas to introduce the next speaker.
Our next speaker is Dr. Jashira Mohammed Kutti. She done her MBBS from Government Medical College, Calicut, and DNB Family Medicine from Aster MIMS, Calicut. And she had MRCP UK in 2023. And she's working as a senior specialist in Aster MIMS, Calicut, and is in charge of the health checkup department and the Aster home care department. And she is also the DNB coordinator of DNB Family Medicine program in Aster MIMS, Calicut. Over to you, Jashira.
Good afternoon. I express my sincere thanks for giving me this opportunity to stand in this dais and present. Today, my topic to present here is navigating oral ulcers. So oral ulcers are common clinical presentation we see in our day-to-day practice with varied etiology. They can range from benign self-limiting lesion and it can be a sign of systemic diseases. So understanding the underlying cause and proper management is crucial for us. So as our beloved sir said, 90% of our diagnosis come from clinical history. So we should have a good focused clinical history regarding any clinical symptoms. So we have to know where is the lesion, the involvement of the tongue or all the oral mucosa, the color and quality of the lesion, whether it is ulcerated, erythematous, pale lesions, duration of the time of the lesion if the patient have noticed the time, change in the lesion, is there any recent change in the size, shape or color of the lesion, and associated local symptoms like bleeding from the lesion, discharge, irritation, pain, and also any enlargement of the local lymph nodes. Along with that, we have to gain a good history of systemic signs and symptoms. Like if a patient have recurrent ulcer with fever, rash, joint pain, red eye, we have to think of connective tissue diseases like SLE, Behçet's, etc. If the patient have associated GI symptoms, we have to think of inflammatory bowel disease. Even though rare in our place, celiac disease also we have to keep in mind. And a good medication history, like any recent change in medication, any use of any recent intraoral preparations, and a good history regarding tobacco use. We should know what product is used and how are they using it, how much and where they are keeping, especially if they are using betel nut, which part of the mouth is kept and for how long. All an extensive history regarding the tobacco use should be taken. In the same way about the alcohol use also. Next, about medical history, whether patient is already diagnosed with autoimmune disease or any history of any malignancy, any recent transplant history on any immunosuppression drugs or undergoing any active cancer treatment. And commonly we see any history of any recent dental works, like use of any dental appliance, like any dentures or any amalgam fillings in the in the dental area. And after history, a good physical examination will aid to our diagnosis. So examination should be done in a proper way. Intraoral examination, not just looking at the lesion, we have to wear a glove and under good illumination, you have to palpate the lesion so that we can understand where it is located perfectly, the color of the lesion, the size, the quality, and by only palpating we can understand the texture, whether it is soft or indurated, and the tenderness. Whether it is tender or not, only by examination we can find out. And we cannot just stop with doing intraoral examination, a thorough extraoral examination, all the perioral areas, lips, face, neck, all the neck lymph node should be palpated. And examination is completed only after doing a complete system examination according to the history you gained initially. So before going into difficult ulcer pictures, common variants I'll discuss few. Leukoedema, you can see in the first picture, it is a common finding. It is a white, grayish alteration in the oral mucosa. It will be usually present both oral mucosa, both sides, symmetrical, and it usually typically disappears when you stretch the oral mucosa. It is very common and it is very benign condition. It's a normal thing. Next is fordyce granules, in the same way seen symmetrical bilaterally on both buccal mucosa. And this actually represents ectopic sebaceous gland, nothing more. And it is very common in all, 90% it is common in the general population. And next is physiological oral pigmentation seen. This is usually commonly seen in dark individuals. Another commonly seen are mucocele, cyst in the buccal mucosa. And the next picture is the torus palatinus. It is asymptomatic, just a bony overgrowth in the hard palate. It may be present since childhood, so it is it is a benign lesion. There is small tissue overgrowth in the tongue is oral fibroma. These all are benign lesions. Next commonly seen in the OPD is hairy tongue. It is just a retention hyperkeratosis of the filiform papilla present in the anterior two-thirds of the tongue. Because of this hair-like projection, the bacteria colonize more in that area, causing that dark pigmentation. So the main symptoms will be only just halitosis. The concerns are with their visual presentation. Otherwise, it actually lacks in symptoms. Hairy tongue respond well with increased dietary fiber and brushing the lingual dorsum or scraping the tongue. Next, first picture is Mosaicatio baccarum. That is just due to the habitual cheek biting. White plaque is there in the occlusal surface of the dentition. It's very common. So from here, we have to take history that whether there is any habitual cheek biting. And next picture shows the frictional keratosis. That this is due to that area, the whitish plaque area is due to chronic friction there, chronic trauma due to the ill-fitting dentures. So that also we have to take from the history whether they are using any dentures or not. Next one is the common thing after ulcers. And very commonly in our OPD, we can see herpes simplex virus infections, fever, blisters, can be seen in one area or all of the mucosal area, varicella, blisters in the palatal area, and hand, foot, mouth disease, small erosions in the buccal mucosa. Another benign lesions are oral melanotic macules, oral melanocytic nevus, and you can see a bluish hue area due to that amalgam filling there, causing amalgam tattoo. And oral candidiasis, in our daily OPD, we see from infant to geriatrics, most of the immunosuppressive patients. So there are very many types of candidiasis, erythematous, pseudomembranous types, hypoplastic types. All these should be well known. Another common variants are median rhomboid glossitis, and you can see the next picture, linear gingival erythema. So after dealing with benign lesion, we as a family physician, we should know what all are the oral potentially malignant disorders before it was named as precancerous lesions. So I'll be discussing here a few OPMDs, that is oral potentially malignant disorders. So first picture is leukoplakia. You can see white patches seen in the oral mucosa areas. So in meta-analysis of 24 studies, it has said that malignant transformation is about 9.8%. So it is our duty to find these lesions on regular visit and follow them up and see that it does not transform into a malignant one. And proliferative verrucous leukoplakia, rate of malignant transformation is nearly 50%. So we should be cautious. And erythroplakia, in the first picture is the erythroplakia. There's a fiery red mucosa, usually seen in the floor of the mouth and also in the soft palate area. And next one is oral submucous fibrosis. This is usually seen those who chew betel nut, very common in our Asian population. And you can see the pale area where induration is happening. And in the last picture, you can see the soft palate is indurated and it has even fibrosed the uvula and uvula has pulled up. So these all present as, in oral submucous fibrosis, the first presentation will be burning of mouth. So if any patient come to our OPD with symptoms, there is burning sensation of mouth, you have to get a good history regarding tobacco and tobacco product use. And at that first visit itself, we have to ask them to stop use and you have to guide them regarding cessation programs. Okay, next is oral lichen planus, the white lacy become stria seen. These are also OPMDs. There is 2.7% risk of malignant transformation is there. Next is oral discoid lupus erythematosus. You can see in this picture, characteristic is there will be punched out erosions. And next is oral graft versus host disease. It's usually a complication of allogenic hematopoietic stem cell transplant. In a study, it has shown that of 17,000 subjects, it has shown that risk of oral squamous cell carcinoma was nearly 60-fold higher than in the general population with these kind of lesion in their mouth after after a transplant. And these till now I have told about the OPMDs, orally potentially malignant disorders. Next, few immune-mediated ulcerations and bullae. These are, first picture shows the bullous pemphigoid. Second is pemphigus vulgaris, where much more deeper involvement causing erosions. Next is paraneoplastic pemphigus. Usually this, if it is paraneoplastic, usually it's severe, erosive and painful. That is the hallmark. And if we see something like this, we have to think of any lymphoproliferative disorders associated with this condition. Erythema multiforme, like you can see the hand target-like lesions with erosions bullae in the orogenital ocular mucosal membranes. And drug-induced, as we know, Stevens-Johnson's, and the anti-cancer treatment, mTOR inhibitors, associated stomatitis are now becoming common, as these drugs are usually prescribed more. And next, about recurrent after stomatitis, another name canker-sores. These are the things we usually come in our family practice. Like about this is, it is characterized by repeated development of 1 to many discrete painful ulcers that usually heals within 7 to 14 days spontaneously. It is typically only about 3 to 5 mm, and it is round to oval ulcer with an erythema and yellowish adherent X-ray centrally. So pathogenesis is usually unknown, but is mostly multifactorial. There is genetic susceptibility, microbiota alteration, micronutrient deficiency, most commonly we say is B12 deficiency. Another is food allergy. In our clinical practice, we see many patients with canker sores, and usually patient itself give us the reason why it occurs. Like I had a patient recently, he's just 35-year-old male, he get recurrent ulcers. At last I told him, you itself from your food or any lifestyle, you just somehow find what is the reason. The next day he visited me, after a few weeks he visited me, that he said, whenever he have mandi, he will get this ulcer. So the patient itself told me the diagnosis. I just asked him to find out. So that was maybe because mandi has that mandi powder, his body is returned to that. So his allergy was mandi. So we can sensitize the patient regarding what may be the reason for the ulcer. And drugs, beta blockers, methotrexate, nicorandil, these all can cause canker sores. Smoking as a cause, and also stress. So regarding management, baseline investigation we can do. A complete blood count itself will tell us about common vitamin deficiencies like B12 and assess the nutritional deficiencies. And also investigation should be done depending upon the history we got, like what the systemic signs and symptoms we got. Pertaining to that, we can do the investigation. General measures is oral hygiene, avoiding the exacerbating factors. In this picture, you can see a poor denture there. So unless and until you clear that denture, that also won't heal. So the etiology should be corrected. In case of, as I said, submucosal fibrosis, and most of the ulcer, if the patient is having a history of smoking, tobacco use, you should advise them to stop smoking. And pain control with topical anesthesias, topical corticosteroids, even topical minocycline, doxycycline can be used. And amlexinose is another drug, anti-inflammatory agent. But treating the cause is the best way to treat the ulcer. If there is refractory cases, we can give short course of systemic steroids also. In other refractory cases, especially in Behçet's and all, we can use colchicine, dapsone, thalidomide, apremilast, and TNF, etc. Even there are laser therapy for oral ulcer treatment. So, sorry, the answer popped up. So, in this few questions, in this picture you can see oral ulcer, genital ulcer, red eye, uveitis. What is the diagnosis? Behçet's. Right. Next question. So, there's a 34-year-old female with fever, recurrent fever and recurrent oral ulcer. Lab showed leukopenia, thrombocytopenia. ANA positive. Already everybody have got the diagnosis. I just want to show that in Euler criteria, we need a score of more than 10. So just from the clinical domains itself, from the history, there's fever, so we got a score of 2. There is oral ulcer, another score of 2, so total 4. And just from doing simple CBC, leukopenia, a score of 3, thrombocytopenia 4. So by the clinical domain itself, we got a score 11. So before doing the immunological test, we have a diagnosis of SLE. So just fever with recurrent oral ulcer, simple CBC, we have to think of these diseases. Another question, a 4-year-old boy with recurrent fever and throat problems. Okay, only when the physician examine, he finds an oral ulcer. Only when the physician examine, there is cervical lymphadenopathy. So only during the flares, he get the oral ulcers and the cervical lymphadenopathy. Anybody with diagnosis? PGs? Not that common, but we see cases. The answer is periodic fever with after stomatitis, pharyngitis, and adenitis. The importance here is if we diagnose this, we can avoid unwanted antibiotics. The main treatment is just a single dose of steroids. So it is essential that we should know regarding all these illnesses. Next question is, you can see oral ulcer, genital ulcer. So we'll think of Behçet's. Next picture shows inflamed cartilage. This is an overlap syndrome. Just for PGs, I have kept this. It is an overlap syndrome of Behçet's and relapsing polychondritis, known as magic syndrome, mouth and genital ulcer with inflamed cartilage. Next picture. In the first picture, there is a rash in the extensor area and recurrent mouth ulcers, enamel changes, and GI symptoms. Nausea, fatigue, diarrhea, weight loss, stomach pain. Not common in this part, but still we have to know. Celiac disease. This is common in our area also. Recurrent oral ulcers with GI symptoms. Colonoscopy showed cobblestone appearance with linear ulcers. Answer? Very good. Right. So the mouth speaks more than words, so it can reveal the silent signs of systemic illness. Thank you.
Thank you, Dr. Shira, for a very informative session on the approach to oral lesions. Next, I invite Dr. Kailas to hand over the memento to Dr. Deshira. I invite Dr. Nadeem Aboti, Chairperson Scientific Committee AFPICON Kerala 2025, to hand over the memento to the chairs. Next, I invite on stage Dr. Jayakrishnan MP, Consultant Neurologist, Thalassery Cooperative Hospital, and Dr. Rashi Kurup, Consultant Family Physician, City Hospital, Ernakulam, who conducted the brain imaging and CT workshop for the family physicians. And I request Dr. P.K. Shashidharan sir to hand over the mementos to the respective doctors. Thank you, sir. This marks the end of our morning academic session. Lunch counters are open in the restaurant. We will be resuming with the afternoon session at 2 p.m.
Good afternoon, everyone. Please come to the hall A. We are starting the afternoon sessions.
Good afternoon all. We are starting the afternoon session now. Please assemble to Hall A.
Good afternoon all. We will be starting the afternoon sessions very shortly. All are requested to arrive at Hall A for the sessions. Next, I would like to invite Dr. Nadeem Abuti, who is the Scientific Committee Chair, to present mementos to the judges of poster presentation. Dr. Rashi Kurup. Dr. Shivapriya,